good evening everyone. Welcome to our first inaugural Asia Pacific Glaucoma Society webinar. Hi, good evening everyone. Welcome to our first inaugural Asia Pacific Glaucoma Society webinar.
Hi everyone, welcome to the Asia Pacific Glaucoma Society Masterclass. I'm Dr. Dalton from Vietnam. I'm the Chief of Glaucoma Department. I'll be your moderator for today. Asia Pacific Glaucoma Society activity. Now I'm working as a glaucoma consultant and visual retinal consultant at the same time in my hospital. I contributed as main author and co-author in some highly cited publication in Journal of Glaucoma, Clinical Ophthalmology, JAMA Ophthalmology, and Nature Genetics. Before we get started, I would like to go over a couple of items. APGS welcomes everyone to become a member of the society. The Asia Pacific Glaucoma Society is open to glaucoma specialists, ophthalmologists, researchers, trainees, subspecialists, associates, and a cooperation with the affiliation in glaucoma. There are many reasons to join the APGS, so that is now shown on the screen. And just a few items which we can share with you. And you can very easy register as a member by scanning the QR code. All APGS members gain access to all recordings of the previous APGS Joy Symposiums, master classes, and webinars. So please complete the survey that will be emailed to you immediately after the master class is completed. The certificates of attendance will be issued after the completion of this survey. One final disclaimer: presentations today and other master classes of our society are intended for educational purposes and do not replace independent professional judgment. So after the conclusion of the events, please send us a short feedback survey that would really appreciate your taking a moment to complete it. So now to start the first presentation, let me introduce our first session speaker, Associate Professor Anthony Tumbocon. Associate Professor Joseph Anthony Tumbocon is the glaucoma specialist practicing in St. Luke Medical Center, Global City and Quezon City, Philippines. He is a past president of the Philippine Glaucoma Society, trustee of the Philippine Board of Ophthalmology, assistant head for undergraduate education in SLMC Quezon City, associate professor and assistant dean for clinical sciences in SLMC College of Medicine. He obtained his medical degree at the University of Santo Tomas, Philippines, and completed his ophthalmology residency training in the same institution. He underwent further training as a clinical fellow in glaucoma at Massachusetts Eye and Ear Infirmary in Boston, USA from 2000 to 2001, and completed another year in clinical fellowship in cornea at the University of Toronto, Canada in 2002. So now over to you, Professor Tumbocon. You are presenting live.
Thank you very much, Dr. Dautan, for that introduction. Before I begin, I would like to thank the Asia Pacific Glaucoma Society for inviting me to give a talk on this webinar. My topic for today is the surgical technique and pearls of glaucoma drainage device implantation, or more specifically, those tubes that shunt aqueous from the anterior chamber to an equatorial plate. These are my financial disclosures, none of which are relevant to this talk. This is my outline. I'll first go into the traditional indications, basic principles and key concept of this procedure, share a bit a summary of the 5-year outcomes of the ABC and the AVB studies, go into detail on the surgical steps for this procedure and share some pearls, then sum it all up. The traditional indications for these procedures are usually for eyes or patients with a higher risk for failure with other types of glaucoma surgeries. This could be eyes that have severe conjunctival scarring, uveitic glaucoma, those who have had retinal surgery, those who have neovascular glaucoma, or maybe even those eyes that have proliferating membranes inside inside the anterior chamber, such as epithelial downgrowth and even ICE syndrome, to name a few. The basic design is that there's a tube that extends from the anterior chamber to an external plate located at the equator, where the aqueous drains beneath the Tenon's capsule and the conjunctiva. There are two main categories: the valve implants, such as the AMID glaucoma valve, and the non-valve implants, such as the bar valve. The AMID implant has a flow restricting mechanism that allows for immediate and controlled IOP reduction with less chance of hypotony. The bar valve implant requires tube occlusion, usually in the form of a ligating suture, until a capsule forms over the plate. And then at around 4 to 6 weeks, and it's during that time that the suture dissolves, allowing aqueous to go inside the capsule and lowering the IOP. These are the 5-year results of the ABC and the AVB studies. They have similar study design, similar inclusion and exclusion criteria. The outcome measures of the AVB studies are a little bit more strict in terms of IOP, the upper end of the IOP, which is 18 millimeters mercury, compared to the 21 millimeters mercury of the ABC. There's a pooled analysis of these two studies, giving us more robust data. And in summary, what they found was both the AMID and the bar valve implants was able to lower the IOP effectively from a baseline of around 31 millimeters mercury. The AMID was able to lower the IOP by around 49%, and the bar valve around 58%. There's the 5-year IOP was lower with the bar valve implant as compared to the AMID, with less medications, and both had similar visual outcomes. The probability for failure was a little bit higher with AMID and compared to that of the bar valve at 49% and 37% respectively. The most common cause of failure was high IOPs at the 5 years. There were, of course, since there was a higher, there were more patients that had a higher IOP with AMID. More patients in the AMID group required additional glaucoma surgery. However, the bar valve group had higher incidence of hypotony, and this is something to keep in mind. So, what does this mean in clinical practice? If you want to have lower IOPs, then you might want to choose the bar valve implant. If you want to avoid hypotony and require immediate and controlled IOP reduction, then you might want to choose the AMID device. In terms of preoperative preparation and planning, you need to examine the anterior segment, especially the conjunctiva and the iridocorneal angle, and look for possible impediments for implantation, such as peripheral anterior synechiae, a shallow anterior chamber, or maybe a presence of an episcleral band or silicone oil. Evaluate for potential risk for complications and failure, and try to mitigate this. Choose the site of implantation, evaluate the pre-op IOP with full medications, and what the post-op target IOP. And this might guide you in choosing which device you want to use. As mentioned earlier, there's two main categories, the valve and the non-valve implants. For the valve implant, the only one being used right now is the AMID glaucoma valve, FP7. There's an FP8 for pediatric patients. For the non-valve implants, we have the bar valve 350, which has relatively remained unchanged since 1990 when it was introduced. We have the AADI, which is similar to that of the bar valve. The Multino 3, which is a totally different device as compared to the first generation. Then we have the newer implants, such as the Paul glaucoma implant and the AMID Clear Path. If you look at the physical characteristics of the various devices, the surface area of most devices is around 350 square millimeters for the bar valve, Paul glaucoma implant, and AMID Clear Path. The Multino is a little bit smaller at 245 square millimeters, while the one with the smallest surface area is the AMID glaucoma valve. Now, does the size of the plate matter? Well, I think to a certain extent, it matters, but it's still unclear whether bigger is really better. It has been shown in an RCT comparing the bar valve 350 and the 500 that there was no difference. Actually, the Barbell 350 was even better than the 500. So larger doesn't really mean better. There are also some retrospective studies. They're not perfect studies, but it suggests that there's no difference between a 250 square millimeter plate versus a 350. But again, the jury's still out regarding this matter. With regards to the plate material, majority have a silicone plate and all have a silicone tube, except for the Multino, which has a polypropylene plate. This is different from the older generations of polypropylene. This has a smaller surface that prevents fibroblast adhesion. For the tube diameter, most of the devices have an internal diameter of 300 microns and an external diameter of 600 microns, except for the Paul glaucoma implant. The internal diameter is half of that of the other devices at 127 microns, and the external tube diameter is 25% smaller at 467 microns. With the surgical technique, most of the devices have similar ways of implanting the different types of implants. I will go into detail the step-by-step surgical technique for the amid glaucoma valve and show a little bit of some differences with regards to the Barbell, Multino, and Paul glaucoma implant surgery. So for the amid glaucoma valve, it has a flow restricting mechanism that allows for immediate and controlled IOP reduction. The amid implant, same as other devices, have fixation holes in the anterior portion of the plate, and most of the implants have plate fenestrations. The plate fenestrations allow for fibrous ingrowth through these fenestrations, stabilizing the plate, after which, when a capsule forms over the plate, it also prevents the capsule from being too large or too tall so that you won't have any motility or cosmetic issues. The superior temporal quadrant is the usual location to place these devices. Dissection is usually done in this area. Um, sorry. Dissection is usually done in the superior temporal quadrant, then extended posteriorly with the surgical plane at the level of the subtenons area. Then the dissection is continued laterally, where a relaxing incision is created to further expose the surgical site. You may also want to do another relaxing incision superiorly if you don't have good exposure. For the amid glaucoma valve, it requires priming of the valve mechanism, and this could be done by injecting balanced salt solution through a gauge 27 cannula to make sure the valve is functional and is patent. And with varying pressure on the syringe, you should have some flow, but as you decrease it, the flow should also decrease. The plate is then inserted into the subtenon's pocket that is created, making sure that the anterior edge of the plate is 8 to 10 millimeters posterior to the limbus. It should go in easily and shouldn't pop back up. The plate is then secured using preferably 8/0 nylon sutures, and the needle-driven partial thickness through the sclera out the suturing hole. It is important to tie this tight so that there won't be any movement. I prefer to see a little bit of dimpling on the silicone plate as on the first throw, then close it in a 3-1-1 fashion. The sutures are important in the first few post-operative weeks. You want to make sure that it's tied tight, after which a capsule forms over the plate is the one that's responsible for the long-term stability of the device. If the suture is a little bit too loose, the plate can go backwards and you could have some tube retraction. It may also go forward and you'll see a tube elongation in the anterior chamber. And in both instances, you don't want to avoid them. At this point of the procedure, I've already created the anterior subconjunctival covering of the tube. I created a scleral flap. Here we're trimming the tubes with the bevel up and aiming for an anterior chamber length of around 2 to 3 millimeters. Prior to creating a track for the tube, we should do a paracentesis so you could have some access to the anterior chamber should you need to refill it. I prefer using a gauge 23 butterfly needle with the other end attached to a syringe and usually handled by my assist. The needle should go in the anterior chamber, parallel to the iris plane, and aiming for an entry at the level of the trabecular meshwork. As I withdraw the needle, the assist injects a little bit of balance salt solution so it wouldn't flatten. The tube is then inserted through this track. It should fit snugly, and there should be absence of any peritubular leaks. This is just an illustration of the proper trajectory and internal entry of the tube. It has been shown that if the tube enters posterior to the Schwab's line and parallel to the iris, there's less risk of endothelial cell loss. One should avoid a more anterior entry or a more obtuse angle in the trajectory because this can lead to some complications related to the endothelium. The challenge among Asians are those patients who have anterior angle closure, whether it's synechial or appositional. One should correct any posterior pushing mechanism first, such as a pupillary block. Here's an example of a patient with a pupillary block with shallow anterior chamber. After just doing an iridotomy, we're able to deepen the anterior chamber and able to insert the tube. If you have peripheral anterior synechiae, so that you could try to do synechiolisis so that you won't have a more anterior entry of the tube, or you could just drive it through the peripheral anterior synechiae. Here on the right, you could see the video here. I was inserting the tube, actually snagging the iris, and actually even went underneath the iris. A simple maneuver that you could do here is just inject viscoelastic to deepen the mid-peripheral iris and the peripheral iris. It's important that there should be no posterior mechanism involved here. Then as you deepen the anterior chamber, you could easily now insert the tube with not much of a problem. So this is the eye. The inferior implant was the one that snagged the iris. You could see post-op that it has good clearance from the iris and the cornea as well. Another option for pseudophakic eyes is inserting it through the ciliary sulcus. This is quite helpful in eyes that have a shallow anterior chamber, or those who have endothelial compromise, or those who have undergone or will undergo endothelial or penetrating keratoplasty. If I go this route, I would still want to visualize the tip of the tube once the pupil's dilated. So if ever the tip of the tube gets obstructed, let's say with fibrin or even with vitreous, you could easily unclog the obstruction using YAG laser. If you have a shallow anterior chamber, like in this case with ICE syndrome, you could create a peripheral iridectomy and insert the tube through the ciliary sulcus. The advantage of doing this in ICE syndrome, you also remove the scaffold for the proliferating endothelial cells and avoid any obstruction from those cells and even the iris as it contracts. Another option is pars plana insertion, but this requires pars plana vitrectomy all the way up to the vitreous base. If this is the choice for tube insertion, I would still want to see the tip of the tube once the pupil's dilated for the same reasons I mentioned earlier. It's also important that the external portion of the tube lays flat on the sclera and follows the curvature of the globe. You could fixate the external portion of the tube with 10-0 nylon sutures, either an interrupted or a figure-of-8 manner. This will prevent vaulting because vaulting can lead to tube exposure, and this is problematic to repair sometimes. So you want to avoid it in the first place. There's other alternative ways of covering the anterior subconjunctival portion of the tube. One can use scleral patch graft 2 plus pericardium, fascia lata, or an innovative way is creating a scleral tunnel using the gauge 23 needle, starting 3 millimeters posterior to the limbus, tunneling intrasclerally and entering the anterior chamber. For closure, I prefer using two 10-0 nylon sutures for the anterior portion of the conjunctival incision, and then one central mattress suture to avoid conjunctival retraction. It is important that this is closed quite well so that you won't have any conjunctival retraction. For the relaxing incision, I prefer using atovicral sutures in a continuous running suture technique. For the amide implant, it's important that this incision is closed properly because you have already aqueous flowing through the device, and leaks can occur at this area if it's not closed properly. After closing, you want to check for the pressure in the anterior chamber. If it's too soft, you could reform the anterior chamber with balanced salt solution to make sure that you don't get hypotony. Just don't overinflate it because the fluid will just go to the plate and exert a little bit pressure in the globe. For post-op care, I give topical steroids for a couple of months and topical antibiotics for a couple of weeks. With the amide glaucoma valve implantation, post-op, I start aqueous suppressants early because this has been shown to decrease the incidence of the hypertensive phase. I usually start aqueous suppressants at around the first week, if the pressure goes up to around 10 to 12 millimeters mercury. The theory regarding the hypertensive phase for the amide glaucoma valve implantation is that you have early exposure of inflammatory mediators in the capsule that makes the capsule a little bit thicker. Another theory is there's an increase in the hydrostatic pressure in the capsule, also making it thicker. Either which way, giving early aqueous suppression helps in decreasing the incidence of the hypertensive phase. Now, for the non-valve implants, for the interest of time, I'll just describe some specific steps that are particular to these devices. I'll describe a few steps on the Barbell 350, Multino 3, and the Paul glaucoma implant. For most non-valve implants require external tube ligation with an absorbable suture with or without an intraluminal stent. So for the intraluminal stent, usually I use a 4O or a 5O proline, and then a vicryl for the external ligation. If you look at the size of the different proline suture sizes, if you put a 4O proline and on a barbell, it could decrease the functional diameter of the lumen to around 100 microns. With a 5O, you decrease it to around 150 microns. For the Paul implant, since the internal diameter of the tube is small, you usually use a 6O proline. Once the external ligature dissolves, the proline sort of acts as a flow limiter. It allows fluid to go in, but it may help decrease the incidence of hypotony, and that's why I like using intraluminal stents, even if I do full tube ligation. This is just a clip showing an intraluminal stent, a 4O proline, and then ligating it to the vicryl. It's important that you have good needle holders, usually macro needle holders that doesn't slip with vicryl, so that you could tie it tight. And the tube should have an hourglass appearance. Then you continue on, making sure that you close the knot quite well so it doesn't unravel or loosen up, because this can lead to hypotony if it does so before the capsule forms. Then you want to check if there's any flow through the tube. You inject balanced salt solution with a gauge 27 cannula and check for any fluid flowing at the distal end. A useful technique is also injecting a column of air and seeing if it goes further down the tube. If that column of air and fluid goes down the tube, then you might still have some flow through the tube, and you might want to add another suture. If the pressure is a little bit elevated and cannot be controlled pre-op with medications, then you may opt to use venting slits. You could use the needle of your vicryl suture to create 2 or 3 venting slits to allow fluid to go out. And this is usually placed more anterior to the legating suture. For the Barbell 350, the main difference is that you need to tuck it in the recti muscles, similar to the Paul implant as well. It's the plate is a little bit wide, so you have to make sure that you isolate and dissect the area of the rectine muscles, more specifically the superior and the lateral rectus. So this is the portion of the surgery where you try to dissect the area and try to expose first the superior rectus. You get a muscle hook up the superior rectus, identify it, take out any fibrous tissue that might be around, then go to the lateral rectus, hook it up with a muscle hook, and then you could already put in the device. Again, you hook again the superior rectus, insert it underneath the superior rectus, the plate underneath the superior rectus, hook up the lateral rectus, slide it underneath the muscle hook, and it could just go in quite nicely. Then just try to center it and double check that both of the lateral edges of the plate is underneath the muscle. After which, again, just make sure you tie the plate tight so there's no plate movement in the early post-operative period, which could give you complications as well. And make sure it's around 8 to 10 millimeters. The rest of the procedure is similar to that of the AMED. For the Multino 3, it's the plate's a little bit narrower, but the material's a little bit rigid. It also has it's also quite curved. So when you place it, it feels like you're putting a cap on your head. So it really quite hugs the globe quite well. In a couple of retrospective studies, they've shown that it's not non-inferior to the barbell. It's just faster to implant because you don't need to isolate the muscles. So this is the Multino. It's a 245 SL245, the S series. You just insert it in the pocket. No need to isolate the muscles. The implantation is similar to that of the AMED. The advantage here is the fixation holes a little bit anterior compared to the rest of the plate, and the suturing holes is a little bit slanted, making it easier to drive the needle through the fixation hole. So again, that's the only peculiarity here. But I think in this clip, I'm going to show what I do with the other end of the Prolene intraluminal suture. I usually cut it, then just tuck it in underneath at the inferior temporal quadrant, so I could remove, if I need to remove the intraluminal stent, I could easily do it even underneath the slit lamp. And this is the photo of the other end of the Prolene suture. I could just cut the conjunctiva at the slit lamp and just pull it out, and it's quite easy to do this in the clinics. For the Paul glaucoma implant, it's a little bit narrower as compared to the Barbell, a little bit longer. But again, the main difference here is the tube diameter, especially the internal tube diameter. It can be used with or without tube ligation. The diameter of the tube restricts a bit of the flow. You could use it with intraluminal stent or a full occlusion. I prefer to use it with at least an intraluminal stent to prevent any hypotony. So this is the Paul implant. You have that well also that you could check for flow if you don't plan to do full ligation. This is just the 6O proline, then the 6O vicryl. I'm doing full occlusion here. So it's easier to implant underneath, to place underneath the recti muscles because it's a little bit narrower. As shown here in this clip, it's easier to sort of just slide in underneath the recti muscles. This is an inferior nasal placement. This eye already had a bar welt superior temporally, so I'm placing it inferior nasally. So it goes in quite nicely. The other key difference here, instead of using a gauge 23 needle in creating the tube track, use a gauge 25 needle to create the tube track. So again, parallel to the iris plane, and then just insert the tube. And then just close it in a similar manner as described. This is just a photo highlighting the difference in the tube diameters between the bar welt and the Paul glaucoma implant. If you see the photo in the lower left, it highlights how small the internal diameter of the Paul glaucoma implant is compared to that of the bar welt. So it's also easier to make sure that it enters to the trabecular meshwork, and because of its size, there's less chance of having endothelial issues when using this device. Now, if you compare, there's a prospective study that came out in 2020 um, uh, describing the 1-year outcomes of the Paul glaucoma implant. There's also a retrospective study showing the 2-year outcomes published in another journal. I use the 1-year prospective study and try to compare it with the outcomes of the 1-year results of the ABC and the AVB studies. And what's noticeable here is that the IOP at 1 year seems to be similar to that of the bar welt, while the complications requiring intervention seems to be similar to that of the AMED. Although you cannot directly compare these three studies, it suggests that it sort of combines the advantages of both the bar welt and the AMED. What's also noticeable is the very low failure rate at 5.4% and very low number of medications. However, you have to take note that the baseline IOP with medications with the Paul glaucoma implant cohort is much lower at 23.1 compared to the 31 in the ABC and the AVB studies. Nevertheless, I think it's quite promising that you have a device that seems to um, combine the advantages of the two most commonly used devices. For post-op care, again, it's similar to the AMED. You use the topical antibiotics for a couple of weeks and topical steroids for a couple of months. If you do full tube occlusion, then you need to restart the glaucoma medications and just adjust as necessary. Wait for the vicryl suture to dissolve, and that's the crucial time of follow-up at around 4 to 6 weeks. And before it dissolves, you try to taper the glaucoma medication before that time to avoid any hypotony. So, in summary, all the available devices seem to be effective in lowering the IOP, especially in eyes that have a higher risk for failure with other types of glaucoma surgeries. We need to pay attention to the details and core concept because this can help increase the chance of success and decrease the risk of complications. You will see some variations in the technique, but if you look at it closely, the basic principles remain. The choice of the device should consider the target IOP and the urgency of IOP reduction. If you have an eye that has significant glaucoma optic nerve damage, you may want to choose a non-valve device since it achieves lower IOPs. If you need immediate and controlled IOP reduction and the target IOP is not that low, you might want to consider using the AMED implant, especially if there are potential risks or complications from hypotony. And other considerations is experience with the device. Also, its availability, and availability doesn't mean also includes the cost of the device in healthcare settings where it's an out-of-pocket cost for the patient. And most importantly, the safety profile of the device. We don't have that much studies yet with the other devices comparing head to head, but all of these devices seem quite promising, especially the newer ones. At the end of the day, these new devices and the old devices just gives us more tools to manage our patients, especially those patients that have a higher risk for other types of glaucoma surgeries. As the safety of the device becomes better, then maybe we could use it more early in the disease process. Thank you very much for your attention. I'm looking forward to the questions later on and a discussion with Professor Paul Chew, who has vast experience in these types of devices. Thank you.
Thank you very much, Dr. Anthony Tumbocon, for your very interesting presentation. So now let's move on to our next speaker, Professor Paul Chew. He's an academic staff in the Department of Ophthalmology, Faculty of Medicine, National University of Singapore since 1989. He was appointed as the head Department of Ophthalmology, National University Hospital, NUHS, in 2008 till 2010. He's an editorial reviewer for numerous medical journals, editor-in-chief of the Asian Journal of Ophthalmology, and the editorial board of clinical and experimental ophthalmology as glaucoma section editor, and has published more than 100 publications. Professor Paul Chew's specialty is in glaucoma surgery and research. He's the director glaucoma division in the Department of Ophthalmology, National University Hospital, and he has been principal investigator in numerous glaucoma clinical trials. He invented and commercialized and now globally available glaucoma MP3 therapy laser machine. He also has uh, the glaucoma drainage device research, which provide enhanced safety and success in the treatment of the severe glaucoma disease. The new implants are designed in NUH and are currently in the advanced state of manufacture. So now we listen to the Paul Chew presentation.
Designed for glaucoma drainage implants, and I'm happy to be able to share this with viewers. Thank you very much for allowing me to be here to speak on how design has been used to increase tube success and safety. And I'd like to just do my disclosures, my financial disclosures here, that I have some financial interest and affiliations with Aridex and AOI. Now, in terms of glaucoma implant design, I think modern tube design has been improved by its use of plate size, tube caliber, whether the absence or presence of a valve is necessary, and in the actual use of implant material. Let's look at plate size first. Plate size is important to improve filtering and to improve pressure lowering. However, there seems to be a diminishing return beyond a certain size. As your plate gets larger, you certainly get more pressure lowering. But as you can see from once you start hitting around about the 300 square millimeters surface area, there's very little additional improvement in pressure lowering over time with increasing plate size. So you really have an optimal plate size you have to achieve. And this is the first of these Goldilocks moments or ideal sizes that we should have. Now, when we actually look at this, the actual total surface area, you can see the Ahmed is 184, the Baba is 350, and the Paul glaucoma implant is 342. However, when you consider that some designs have the rectus muscles, which are illustrated by these black lines, covering part of the plate, you find that the area under the rectus muscle doesn't, of course, contribute as much to pressure lowering. And really, it's the available area that's not covered by the muscle that's available for filtration. This total area that's not covered by the muscle, the effective surface area, of course, is 100%, 184 for the AMED, and however, about almost 30% is covered for the barbell, and gives you an effective surface area of 246. And because less of it is covered on the Paul glaucoma implant, you have an effective surface area of 305, which is very, very close to the 300 square millimeter area that we consider necessary for ideal fluid pressure lowering. And if you look at IOP outcomes, this seems to be certainly reflected here, that you get pressure lowering at 1 year, and that the AMED doesn't quite lower pressure quite as much as the barbell or the Paul implant. However, when we look more closely at this data, you'll find that really, if you look at ABC trial, for instance, qualified success is reasonably high, but that's with medication. Whereas when you look at the Paul glaucoma implants first studies, you get a higher qualified success, and more importantly, better complete success, 19, 31, and 70. If you change the criteria by which you use eye drops to a lower pressure from 18 millimeters to 15, 16 millimeters, then you may have a different complete success. But yet, despite that, the qualified success is still higher than the ABC data. If you look at the AVB data, this actually is even more strict. The AMED and the barbell have about 50 and 56% qualified success. However, if you look at the Pinto data, which is mostly for congenital glaucoma, and for the 2-year follow-up data from Tan, it still is in the 75 to 80% range. And Tan was still able to have a complete success of around about 71% compared to the 8 and 17% that AVB found for the AMED and the barbell. So certainly we're talking about efficacy measures which show that we're getting probably higher success rates and better pressure control overall. Bear in mind, of course, that these designs were not actually ideal, back-to-back comparison studies, so these are just extrapolations. Now, more importantly, medications are fewer at 1 year with the PGI, whereas with the AMED and barbell, you see that they are using about 1.5 to 2 medicines at 1 year, whereas for the PGI, really the amount is less than 0.5 medicines on average. And here's the data. You can see that for the 2-year follow-up, for a group of patients that started with a pre-op of 3.2 medicines, at 2 years, the mean number of medicines was 0.3. And this seems to be similar if you use Cole's data, 0.3. If you use Al's data, which is stricter because he wants to have a lower pressure, it's 1.2. And Pinto's data for mostly congenital diseases, 0.8. So I think that when you have less medications, quality of life is better, and patients have a more comfortable eye without all the side effects of chronic medication. What about tube size? Tube size is both external and internal. You can see that AMED barbell has about 640 microns external. PGI has 467. AMED and barbell have an internal of 300 microns. PGI has internal of 127. Now, this is important because a smaller tube gives you less conjunctival erosions, less corneal proximity, and also when you have flow resistance inside the tube, you prevent hypotony. Let's look at that a little bit more. Here's a barbell. You can see it's quite large. Here's a PGI. It's smaller. It's very close to the preserved flow microshunt, which is put here for comparison. Anterior segment mostly shows that when the tube goes into the eye, there's quite a lot of space between the cornea and the tube, and the endothelium is then probably more preserved by being further away. With a larger tube, like you can see here for the AMED, the conjunctiva, the cornea endothelium is very close to the tube, and this may sometimes result in localized corneal edema if the tube is not well positioned, because there's so little room to play. Internal diameter of the PGI is very close to the first generation iStent, 127 microns, and this gives you full resistance. As physiological flow increases from 1 microliter per minute up to 5 microliters per minute, you can see there's a meaningful increase in flow resistance from about 1 millimeter mercury to around about 3.5 to 4 millimeters mercury, and this is useful resistance compared to a barbell, which doesn't give you any meaningful resistance at the same flow rates. This amount of resistance probably is one of the reasons why the Paul glaucoma implant has much less chronic hypotony. But let's look at some data for safety outcomes then. In terms of hypotony, there seems to be a relatively good number if you look at actually Cole's data. This is acute hypotony. There was very little chronic hypotony. Similarly, here again, there was very little chronic hypotony. These were all acute hypotonies. And if we look at the comparison for the Ahmed Babat data, it seems to be comparable, if not better. The self-limiting shallow anterior chambers were part of the acute hypotony in the early cases at about 14 to 22%. And this is, again, comparable to literature. But bear in mind that we still found that very few patients ultimately had chronic hypotony. Now, how about a valve? How important is a valve? Honestly speaking, valve implants give you some resistance to flow initially, and opens when the flow goes above a certain pressure. But this is still not a very reliable system, prone to malfunctioning valve systems. You can get hypotony, and you can of course have more resistance. Non-valve implants really have to be controlled by using things like the stability system, or stenting, or external tube ligation. Now, variations in internal diameter also result in some resistance in the suture diameter, tube diameter match, and may result in some variation in fast low flow. So stenting may give you some variation, and you have to look at the outflow when you're performing a stenting to ensure that you're getting the right amount of fluid coming out of the tube. But be that as it may, in the presence of a smaller plate with a valve, you get hypertensive phases more commonly in the Ahmed, whereas in the barbell, in the larger plates, you get less hypertensive phases. Implant material is very helpful for the surgeon. The only thing to mention here is that thickness is relatively similar, but because it's a low profile and very soft material, it's easy to implant below the muscle. And many surgeons have commented that the transparency of the plate allows you to also see whether there's anything below your plate, making sure that you actually have the plate either above or below the muscle more certainly. You can see that because of the low profile material, the bleb on the PGI is diffuse and low, compared to a slightly higher, more localized bleb that you find in the typical Ahmed. And of course, the tube is smaller in the anterior chamber in these eyes. So in summary, glaucoma tubes and shunts are increasingly popular. If you understand the shunt design limitations, you get the better outcomes in terms of complications, success, and IOP control. The PGI is an effective and safe glaucoma tube shunt in the early data that have come out. I'd like to thank my colleagues and my team for helping me to collect and to analyze this data at NUH Singapore. Thank you very much for your attention. And now I'm open to questions.
Your knowledge, Professor Kuan Chew and Dr. Tumbocon. Now we will start the Q&A session. Please type your question into control panel box, label questions, and remember to hit the send button. So thank you very much, and we already have a lot of comments from the audience. You can see the comments box, and I think there are many very interesting question for you, Paul, and also for Anthony. So the first question is maybe for both of you. Sir, which glaucoma drainage device do you prefer and reason? Maybe two. Anthony, please answer the question because you have a variety of choices in Philippines.
Okay. So initially, my go-to device was the Barbell 350. Again, it depends. The choice of the device depends on what you need. If you need an immediate and sort of controlled IOP reduction, usually in these eyes who have secondary glaucoma, not much optic nerve head damage, the level you don't need that low an IOP, I might choose an Ahmed glaucoma valve. If there's significant optic nerve head damage, then I would go with the non-valve devices. Before, my go-to device was the barbell. with newer devices, especially with a PGI, the Paul glaucoma implant, that seems to be a little bit easier to handle. And of course, it's a safety. The small tube diameter, it makes it, you give a little bit of this the safety there, especially initially when I used the Paul implant, it was with no intraluminal stent. Then I started using it with an intraluminal stent. um, it really decreases the chances of hypotony, I think, because once you put the 6O, the functional diameter of the internal tube, correct me if I'm wrong, Prof, would be around 28 to 77 microns if you put a 6O nylon inside the tube.
Yeah, yes, certainly it all, there's quite a lot of variation in 6.0, so
Yep.
that's what we aim for. Yeah.
Yeah. So again, it depends on the type, the situation, the patient, the eye. If I have extensive scarring and there's a lot of there's a lot of impediments to putting in the plate, like for example an episcleral band, I might go with a smaller implant like the Multino 3. I'm also getting good results with that. But I think a plate size of 250 or more is quite good in getting low IOPs.
So how about you, Paul? Because in your presentation, you show that there are many advantages of your own implant, the big size and the smaller size of the tube. And do you think that that implant is can be good for all situations?
Thanks, Dr. I agree with a lot of what Tony said just now, but we've also had quite a lot of experience gained over the past 3 years, 4 years of using the implant, and we're getting better at learning how to manipulate it to get consistent results. Today, in our center, truth be told, we're getting very consistent anterior chambers, very good immediate post-op flows. We don't ligature anymore. We do stent and we find that the consistency of getting a normal pressure on day one with the deep anterior chamber is very high now. And what we're working on now isn't so much preventing hypotony as uh, working on ways so that we don't have to pull the stent as often, so that we have less post-operative, work to do in the clinic. So we're getting more ambitious actually, and we are, yes. So therefore, we are using it quite widely now.
I have a
So
question, Prof.
Hi,
Um,
yes.
would you use a smaller Prolene size suture for the intraluminal stent? Have you tried it? I haven't tried using a 7.0 or something smaller.
Some people like Keith Barton have been trying, have used occasionally used sevens. We are actually thinking of doing a systematic evaluation of 6 versus 7. Bear in mind, there's quite a lot of manufacturing variation in the proline, so
Yes.
it's a little bit hard to standardize this. But yes, we are working on that. The sevens may be great because if it is able to give us enough flow resistance, we may not have to pull it as often, and that gives us a lot less work in the clinic post-op.
So am I correct to assume that you use intraluminal stents in all of your Paul implant devices now,
Uh,
or not?
Yeah, well, some of us do use all, and some of us still have occasional cases where we don't
Okay.
stand. But yeah, but stents are comforting. Stents
Yeah.
are reassuring for us.
okay, very interesting. So the next quick question is how to treat the hypotony post-operation in AMAT and Barbell. Maybe Anthony?
Okay. Again, figure out first what's happening. You could have a peritubular leak. You check that. For the AMED or the non-valve device, you want to check if there's any peritubular leak. You might get some hints because you have the conjunctiva and the area that might be a little bit elevated. It's not going posteriorly. Check for maybe inflammation that may be causing the hypotony. if if it's it's a malfunctioning valve of the AMED, then treat it like a non-valve device. Just open up the conjunctiva. You don't need to remove the tube or go through the plate, and just ligate the tube. And for a non-valve device with hypotony, I would also do the same. I just open up the conjunctiva, then pass the needle sort of reverse underneath the tube, then just tie it with a vicryl. And after the pressure is going to go up, just manage it. Then when the vicryl suture dissolves, then you should have good pressure.
Okay. So for the valve devices, do you need to test the device before using? What do you think
You
of
need
that opinion? How to test the valve system is to know that it malfunction or not.
yeah you need to check it always. So you need to prime it. So just make sure that there's a little bit of resistance as you irrigate the tube. As you decrease the pressure in the plunger, there should be decrease also in the amount of flow. Try not to over irrigate the valve mechanism, because sometimes there might be an issue. I think with the older AMED implants, there was some variations in terms of the valve mechanism, but lately I haven't encountered such. Paul, Prof?
Yes, Tony, I agree with you that we do have to prime, and because the priming is actually rupturing the silicon elastomer membrane, there is a little bit of uncontrollable aspect of how it will tear, and that's a bit random. However, we mustn't forget that also, if we're talking about acute hypotony in AMEDs, it may not be the valve that's not working. It may just be the patient's a chronic squeezer and a rubber and pressing on their eyes post-op. And even if you have a valve, if you're pressing on the eye and then letting go, you're going to get hypotony. So bear in mind that any valve system cannot prevent patient squeezing and pressing on the eye and then letting go. And this is an issue that is a limitation of a valve.
Okay.
So I think you're going to get hypotony in those type of patients no matter what.
Okay, so thank you very much. So I have feeling that in the past when we prime the AMED implant, you need to press hard on the plunger, but now I feel almost no resistance. What do you think of that?
I think they made their silicon elastomer membrane thinner, and they probably couldn't make it more consistently thin. So this is more manufacturing reliability now. They've got more consistency in the manufacturing.
And the next question: any tip in the tube failure in ICE syndrome? So, it was revising or even yak laser or the tube occlusion. I think just the question is about the iris tissue that stuck into the tube lumen.
Prof, you want to go ahead?
Sure. Certainly, I think any tube's tip that's blocked, you clear. Yes, depending on what the material is. If it's iris, you can yag it. If it's vitreous, you can pull it out. Usually, because the plate is already scarred, you're not going to get any more surge or flow. So vitreous is not going to find its way back in. Neither is iris. So yeah, I mean that's pretty standard. I think any kind of tip, whether it's ICE or anything else, if your tip is blocked, you have to clear it.
Yeah, I agree with Prof. You just also try to prevent it in the first place. So with my patients with IC syndrome that I need to put a tube, again, you have to remember there's a proliferating endothelial cells that sort of wraps around the anterior chamber, the iris, and there's a tendency to wrap around the tube as well. So just creating a peripheral iridectomy and putting the tube at that area of the iridectomy, remove the scaffold for those proliferating endothelial cells and decrease the chance of the tube getting obstructed.
Okay. The next question is: do you think that sulcus placement is best in pseudophakic patient? Paul?
I think sulcus fixation isn't the issue. The issue is what's your anterior chamber like. If you have a very shallow anterior chamber with lots of synechiae, then yes, go for sulcus fixation. If you have a well-formed anterior chamber and an open angle, then you can put it in the angle. I think this is it's not a matter of pseudophakia. It's a matter of what your angle is doing.
Yes, I agree, because sometimes you try to put the tube under the iris into some cause sometimes it can cause bleeding. Do you think that, Anthony?
Yeah.
Have
Yes,
seen
there's all yeah, definitely there's a risk. There should again, it's always about risk and benefit. If you have a flat anterior chamber, then or severely scarred, then you could think of putting in the sulcus. If patients going to undergo endothelial keratoplasty, put it in the sulcus so that you won't have that air bubble obstructing it, because the cornea guys will hate you for that. If you have a tube, if they cannot inflate the eye and do the endothelial keratoplasty properly. Also, if you have endothelial compromise, then you might want to consider sulcus placement. It's an option, but like always about risk and benefit, because it's not without risk. And sometimes you don't get it tilts the IOL if you go a little bit more posteriorly. There should be some justification going to the sulcus, but it's a valid option.
Okay, thank you. Another question. Hello, sir. Is there a preferred timing to remove the intraluminal stents if needed? Anthony?
Prof? Okay. For the intraluminal stent, what I use it for is not for full occlusion. I use it to limit the flow. If you look at the ABC and the AVB studies, you have that hypotony. So the intraluminal stent sort decreases the functional inner diameter so that you'll have some resistance. Because sometimes once the vicryl suture dissolves, the capsule is not so well mature yet, that allows a lot of aqueous to flow through. Now, if you decrease the functional diameter of the tube, be it a poly implant, barbell, or Mitino, then you will decrease the chance of hypotony as well. That's my thinking with this. So uh, it's a flow restricting device. Even with the newer implants such as the the Amid Clear Path, it actually comes in with a 4.0 proline already, so makes it a little bit easier as well.
Thank you. The next question, may I ask if you use any anti-fibrotic MMC routinely in GDD? And if so, what concentration? Paul, please.
Okay, we have in our original multi-center studies, we had the guys in London using MMC routinely because they have a habit of doing so. So Morpheus was using MMC, and in our center we absolutely use none whatsoever. The results for both centers really very comparable, very similar. So for us, I think we're pretty convinced that in our current techniques, with just putting a bit of Kudo patch over the plate and a bit of viscoelastic, we really don't need MMC. That's
Yeah.
my take on it. Yeah.
So I think maybe a reason for that is because of the fibrotic tissue is very thick and very rich in the phonics. So I think the MMC is not really worked. So another question also for you: viscoelastic in anterior chamber in pole implantation. Please, Prof.
Yeah, sure. No problem, Conrad. Uh, I think if you have a stent and you use and you've controlled the outflow at the back of the plate, you probably don't need viscoelastic. But if you have visco in the AC and you just put slightly shorter stent, it's probably okay. I mean, we don't really have much problem. And anyway, you can always press on the paracentesis for the first day or two if you feel that you have pressure that's undesirable. But in general, it hasn't been a problem for me at least.
So I think because of the matter of time, I will have a very short time for another quick question. Uh, my own question for both of you. If you penetrate the globe when you fix the disc, is it dangerous? Have you ever seen that? Have you ever met that? When you fix the suture through the eyelid of the disc, and you penetrate into the globe, you see some fluids going out. You know that the needle is go too deep, and you saw the fluid coming out. So is it dangerous? And
Oh,
what to do next?
so if the needle went through full thickness to the sclera,
Yeah,
is that the
yeah, yeah,
question though?
yeah.
Uh, Fortunately, it hasn't happened. I'm not sure. It hasn't happened to me yet, or even my fellows. How about you, Prof?
Are you talking about the fixation suture for the plate, Dotan?
Yes,
Yeah, yeah.
going through full thickness.
Yeah, I'm always slightly anxious, but in general, it hasn't been a problem for me yet.
So because
Yeah.
I have my assistant, who did I met too, and he called me back because of that problem. She penetrated into the blood and saw some fluid coming out, and so I think maybe we need to keep calm and keep
Yeah.
doing the remaining of the procedure, and maybe a few days after the surgery, we dilate the pupil and see any tears on the retinal and do some laser.
Yep.
Yeah.
I've seen one way back and during the extracapsular cataract extraction days during when they were fixating through the superior rectus, but it's
Yeah.
a bigger suture, and what was done was just dilate intraop and just do indirect LIO, laser indirect ophthalmoscopy. But the suture that we use is a little bit small. If ever you go full thickness, maybe there's not an issue, but unfortunately it hasn't happened to me yet.
Okay. So thank you very much. And because of the matter of time, I would like to wrap up our webinar. Thanks all speakers for the participating in the webinar, and a big thank to you to all the attendees today. This concludes the Asia Pacific Glaucoma Society Masterclass on Glaucoma Drainage Devices. And please join us next month for another engaging webinar brought to you by APGS. And the topic will be confirmed shortly. As mentioned earlier, we will receive a short survey to provide your feedback on this event, and the certificate of attendance will be issued after the completion of the survey. The participation will help us to improve on the future professional development offerings. Please also do not forget to like or subscribe to the channel AP Glaucoma Society, and to be notified of the upcoming APGS activities. So have a wonderful day or evening, depending on where you are, and you may now to disconnect. Thank you very much. Thank you, Paul and
Thank you.
Anthony, and see you.
See you.
See you.
Thank you, Dot. Thank you, Prof.
Thank you. Nice
Thank
seeing
you for attending, everyone.
Thank you. Bye.
Bye bye.